It now gives me great pleasure to introduce my friend and colleague, Dr. Gideon Koren. I've known Giddy for 30 years. Dr. Koren has devoted his career to pediatric pharmacology and maternal fetal toxicology, publishing over 1,500, just as 1,500 articles. He is director of the Motherisk program, actually founder and director of the Motherisk program, and senior scientist in child health evaluative sciences at the Hospital for Sick Children in Toronto. Dr. Koren is a professor of pediatrics, pharmacology, pharmacy, and medical genetics at the University of Toronto. He is also the Ivey Chair in molecular toxicology in the Schulich School of Medicine at the University of Western Ontario, and a recipient last year of the Sunray Apney Lifetime Achievement Award in pediatric pharmacology. Please welcome Dr. Gideon Koren.
Thank you, David. No, it's not my slides. Thank you very much, David, for the kind invitation. I want to thank Pregmedic to take this initiation. The topic of women's health and as related to pharmacology is not often discussed, clearly not enough. While David is locating my slides, I'll tell you we're going to change a little bit our tenure now. We talked about changes between women and men. Now I want to present to you a problem that comes from that change and show how easy it's to orphan women from the advance in pharmacology that we all experience. Thank you so much. So first, I apologize. One of my slides, the acknowledgement of support, seemed to have not come through. I am supported in my research at SickKids and in London by Novartis, by Bayers, and by Duchenne in Canada. Although none of them relates to the topic of the discussion today. So, let's pretend that you are a panel for your local regulatory authority, say FDA or Liechtenstein or whatever. And here is the problem. There is a drug on the market for a woman's condition called biliary stasis. Those who had biliary stasis or know patients with it cause huge pruritus. Women really, really suffer in pregnancy. And there is a drug on the market. There is now a company that wants to bring a generic form of that drug. So this is the situation. They come to see you, and you tell them that they will have to do bioequivalence study. To remind everyone, I know many of you are familiar with this, but bioequivalence will entail to take a bunch of healthy people and to give them drug A, the reference drug, or later on the other drug, of course, in a randomized manner. Crossover. Some will receive that first, some will receive that first. And in order to be, thank you, and in order to do bioequivalence, you will have to prove, as Don said, that the two are not different in more than 20%. Between 80 to 120. So, for example, the new drug can have higher exposure, more levels, but not more than 20%, or as low as 80%. Similar differences should occur in the Cmax, the peak level. So you send them to do the study, and they come back, and they report to you that they are very proud to have studied 15 men, average age 30, not a single woman. And you are the regulatory agent. So, question to you, how many would approve it? How many will not? I'm sorry I have to wake some of you up. How many not? Okay. So that's good. So maybe we can stop the lecture here. Well, the reality is very different, actually. The US Drug and Food Administration, Food and Drug Administration says, if the drug product is intended to be used in both sexes, the sponsor should attempt to include similar proportions of male and females in the study. Focus on attempt, so it's not a demand. It's an attempt. Alas, 95% of all studies are done on young male volunteers. Even for drugs such as for biliary stasis, morning sickness, conditions that cannot happen to men unless they find a way to become pregnant. So this is the issue. So first question, why is that? Why is the regulatory agencies all over the world, by the way, it's not North American, EMA is the same, and true for other, why do they not see the light? Actually, it's based on logic. The logic is, even if men and women are disposing drugs differently, as Don showed us, it's not really relevant because we compare the same individual with the two drugs. So actually, we kind of taking apart the fact that men may be different from women, we assume that the same GI and the same volume distribution, the same elimination will occur to that man that compare the two drugs. So we compare two preparations using the same individual as his or her control. We already decided it's mostly his. Hence, being a man or woman does not really matter because differences between the two formulations, if they exist, will be apparent whether one studies either male or female. Kind of superficially it sounds logical, but there is an assumption here. What's the assumption? This is based, what we just said in a minute ago, on the hypothesis that intra-individual variabilities in bioequivalent are similar between men and women. Just to stop for a minute, this means that if you do 10 men or 10 women on the same protocol, you will get not just the same bioavailability differences, but the variability will be the same. We'll discuss it more, but just for a minute, variability is very important. The larger the variability, you need larger sample size to show sameness or differences. So are the variabilities the same? That's the first question I'll try to address. Are they really? So we challenged that. We did a systematic review with Stuart MacLeod and with our friend from Norway, Dr. Nor Deng, this paper was published in CPT last month. And it goes back first, as Don showed you, to an important paper done by Chan out of the FDA, CEDAR. They reviewed more than 23, but I'm relating to 23 studies submitted to FDA where really both men and women were mixed. And because they had access to that material, they could reanalyze it, men versus women. So that's the basis. By far the largest such study. So they compared the bioequivalence between men and women. And here's a point. The conclusion of that paper from 14 years ago was that there are no differences in overall bioavailability. But as Don picked it up, that's a very wrong conclusion because there were statistically different results between genders or sex, it really should be sex, in 5 medications with respect to area under the curve, and 18% when it comes to peak plasma concentration. Let me show you more in details, because I want to show you how this is important in terms of clinical. What does it mean? So here are the 5 drugs. You realize this is what was submitted to FDA. So it's not something that they chose to study. This was available to them on a database. For example, look here, alprazolam. The variability among male was hardly 5%. Among women, 30%. This is huge, because it means that if you study women, we'll need many more women to be able to see sameness or differences. To remind you, variability affects to the power of 2 the numbers, not to the power of 1. So if you have twice as much variability, you need 4-fold more patients to show sameness or differences, whatever you wish. NAPA, 2-fold. And the other direction, look here. Nitroglycerin. Cimetidine. Women had less variability than men. Ketoprofen, twice as much. In all fairness, in general, women had more variability, as Don mentioned already. More variability means that you cannot come to the conclusions as you can with men. Or not with the same numbers. Sorry. The differences between men and women in variability at times were quite large. Look here, 42% differences between 16 and 45 for nitroglycerin, because there was more than one study on nitroglycerin. And the opposite, with napite, men had larger variability than women. Even without knowing anything more than what I showed you now, unless you had knowledge ahead of time to which direction it goes, you cannot draw conclusions from men to women. You cannot say, I expect variability in women to be twice as much and put it into the calculation. You cannot predict. What does it mean practically? So this means that sex differences will have major implications to the conduct of this type of studies. Let's take one example, alprazolam. I took it because it was in what this FDA study showed. In males, there was marginal intra-subject variability, which means that small numbers, maybe 5 or 10, will be enough to show sameness or differences. In women, the variability jumps 6-fold, hence a much larger number will be needed to be able to say that the drug is bioequivalent. And as I said, in most cases, there was much larger variability among women than men. But it's more than that. Oftentimes, and I think Don mentioned that too, there are examples where the bioavailability itself in men, not just the variability, the bioavailability itself was higher in men than in women. So imagine now that by testing men, a generic drug may be deemed bioequivalent when in fact in women will achieve much lower area under curve. And the drug cannot be approved as interchangeable. Or in other words, you cannot even be sure that men and women have the same bioavailability. And why is that? Because it's not just the fact that someone is his own control. There are other differences which we'll dwell now into. So it's not true to say men and women are the same because they serve as their own control, which clean out any other differences. Here are some examples. Cycle-dependent changes. Men, to the best of our knowledge, to 213, do not have cycles. They do have many other cycles in their life, but not hormonal cycles. In women, depend when you study. Depend when you study, you may get different values. There is fluctuating hormonal status among women, during a menstrual period, and it may affect absorption, distribution, metabolism, and secretion of different drugs. Look here. This is a drug that was studied separately. It's not part of the chance study. Several important pharmacokinetic parameters for ranitidine were different, and bioavailability was different based on when you studied it during the menstrual cycle. So how can you study men for that? What would you gain from it? Now, ranitidine is a good example. Women have huge increase in reflux in pregnancy. And actually, during morning sickness, which affect about 80% of pregnant women, a lot of them suffer for reflux. And actually, reflux makes the morning sickness much worse. So ranitidine is a very important drug for women, and you cannot apply results in men to what will happen to women. But it gets even more interesting. A medication that we take is not just the active drug. It has numerous inactive ingredients that also may affect the story. So here's some example. Often, a generic drug may differ from the reference formulation in the presence and levels of inactive ingredient. That's how you make a generic. You prepare it differently. Here is an example, a very, I think, powerful example. Polyethylene glycol, which is a very common constituent, inactive constituent. A study showed that polyethylene glycol enhanced the bioavailability of ranitidine in a dose-dependent manner among men. And guess what? Polyethylene glycol decreased absorption up to 24% among women. So how can you do study on men to disclose those differences? It's totally inappropriate and should not happen. What does it mean clinically? We go back to the example of a minute ago, the ranitidine. If a ranitidine bioequivalence study were done in men only, as they are, the dose of the generic product using polyethylene would have to be 60% lower as compared to the reference drug because it changed bioavailability. If this regimen were then translated to women, as done in, as we said, in almost 100% cases, the reduced dose of the generic and the 24 decrease in bioavailability in women would render their dose subtherapeutic. They will receive much lower dose based on wrong conclusions from men when you study it with ethylene glycol. So I just made here an example that comes from real studies. It's more than that. Don touched upon it. Women systematically seem to have more adverse events than men. And it may have many reasons, from taking more drugs, reporting more, to dose per kilo larger, and so on and so forth, and pharmacodynamic reasons. The rate of absorption of excipients within formulation may affect frequency, onset, and severity of adverse drug reactions, if the reaction is to the excipients. And by the way, bioequivalence studies, although they measure area under the curve and Cmax, also supposed to report on adverse events. Don actually is responsible for much of this literature, and he covered it nicely. I'm not going to repeat it, but the very fact that much of the adverse events are more common among women is a very good reason why we should not study men for bioequivalence, because the excipients may make some of these reactions. So what's the consequences of the problem I brought to you? Dear committee, you served as a committee. Ignoring gender differences may cause either less effectiveness or increased risk of adverse drug reactions. And that tied with the fact that many drugs removed from the market by the FDA in the last few years were more because of women's reactions and not men's, such as the QT syndrome. So the context here is that we are orphaning women, big way, by allowing drugs to be tested in men rather than in women. So the big question, why are women not included in bioequivalence studies of drugs meant for them? Well, I hope I won't be too cynical. Before the 20th century, in many British theaters and other in Europe, men used to perform women's roles in theater as a reflection of sexual puritanism. I don't think that's the issue today. Even worse, till recently in many countries, women are not allowed to vote. And this reality kind of men knew what's good for women. I must tell you a personal story. In the 70s, when I was still in Israel, we had a visitor from Switzerland, a very intelligent man who worked for the foreign ministry of Switzerland. And we kind of, myself, my family, he was a family friend, asked him, how come women are not voting in Switzerland at that time? And what he said, you mean what, you know what you say? If a man have eight daughters, he will have a huge vote. It did not even cross his mind that they will have their own mind and maybe vote differently. So this is paternalism at its best, that you can test men to decide what's good for women. And why is that happening? Of course, it happened because companies perceive it more nuisance to study women, mostly because they may become pregnant. But they are not pregnant women. These are women, healthy volunteers that can participate in those studies. These are short studies. We're not talking steady-state studies. We're talking bioequivalence, which at best is a short study. And today, a lot of tasks that were done only by men are done by women much better. In our hospital, most new surgeons are women, not men anymore. And it goes on and on. So I think we have to depart from that approach, that we test men for women, and clearly there are no ethical basis for this. As a matter of fact, there's a strong ethical basis not to go that way, of ignoring women. So clearly the regulatory reality today is not good for women. Men do not know what's good for women. The claim that it's easier to study men than women is absolutely not true. Young women, students, healthy adults, what's the difference? There's no difference at all. The fact that a woman becomes pregnant for bioequivalent study is simply not an issue. Now, to make it worse, if you remember the first FDA slide, you should attempt to have also women. It makes it even worse, because then they mix the two populations. None of them, men or women, have enough power, and actually the results will be something which is clearly not representative of anything. So the attempt to study a drug for women in a mixed population is not any better. Why would it be better if women are different from men? Study women, study men if you have a reason for it, but don't mix them. It doesn't make any sense. Now, here is some examples for the sources of variability. This was covered both by Mary and mostly by Dawn. In pregnancy, of course, these changes, basically, drug levels tend to decrease for most drugs. There are several cytochromes that come up, as Mary said, or did not change. But for most part, levels are lower. For drugs with low therapeutic index, this effect may be much more important. Digoxin, that Mary mentioned, lithium, and so on and so forth. But in general, there's much more variability because other things are moving. It's not just being a man or woman. A woman is on the move herself because of the pregnancy. So if a woman is first trimester with morning sickness, she is not a third trimester with morning sickness because a lot of her physiology will change by then. And actually, again, because we talked bioequivalence, let's look at absorption. Gastric emptying and small intestine motility are reduced in pregnancy. And of course, many women in pregnancy may have morning sickness, up to 80%. So it's another variable that may affect how much a drug is absorbed, on top of all the changes we talked about. I use this to further augment the argument that don't test men for a condition which mean for women, especially if she's going to be pregnant. So basically, this repeats the tone that I said. And of course, because of that, these changes may affect not so much steady state levels, but single dose levels, say of antiemetic, of analgesic, may have enough differences to affect peak and trough in women. And all that, although the bioequivalence study that the agency wants to see does not address those, we as clinicians should think about it, because it increases the variability even more. And on top of women having more variability anyway. And the nausea and vomiting example, which herald anything in pregnancy. And whenever we study a drug in pregnancy, the question whether the woman have and how much of morning sickness becomes very important. The same is true for other sources. I just don't want us to be totally focused on GI absorption. Inhalation. For example, all the drugs given for anesthesia, or most of them, are given by inhalation. And indeed, the dose requirement for volatile anesthetic agents, such as halothane, may be reduced in pregnancy because there's much more blood going into the lungs to be able to take the drug in. Or another example, intramuscular delivery may also change, increase tissue perfusion secondary to vasodilatation. So the drug may be effective more quickly, and the kinetics may change too. Yes, I think you heard enough. In summary, I just wanted to say, I believe we looked at things the wrong way, and some of our assumptions were fishy. Thank you.